Good afternoon everyone. Today's topic for the PG activity is membrane disorders of the leukocytes. Leukocytes are the cells of the immune system. They are involved in protection of the body against the infectious diseases and the foreign invaders. They ingest the offending agents, kill the bacteria and other microbes and eliminate the necrotic tissue and foreign substances. Before going into the disease proper, let's see first how leukocytes are formed. For that, hematopoiesis, the physiological process of the formation of the blood cells is known as hematopoiesis. It starts from the third week of the embryonic life in the yolk sac. After that, the cells they migrate into the liver. That is known as the hepatic stage, and after that, the bone marrow that becomes the sole site for the responsible for the hematopoiesis process. All the blood cells that are derived from the pluripotent hematopoietic stem cell, they are present in the small numbers in the bone marrow. Some amount of the hematopoiesis also occurs in the liver and the spleen. From the hematopoietic stem cells, we have the common myeloid progenitor and the common lymphoid progenitor. From the common myeloid progenitor, we have the megakaryocyte erythroid progenitor and the granulocyte macrophage progenitor. From the megakaryocyte erythroid progenitor, the colony-forming unit megakaryocytes, they develop into the platelets, and from the blast-forming unit erythrocytes, they form the red blood cells. From the colony-forming unit granulocytes, we have the myeloblast, then comes the promyelocyte, then a myelocyte, metamyelocyte, the inform and the neutrophils. From the colony-forming unit macrophages, we have the monoblast, monocyte and the macrophages. From the colony-forming unit eosinophils, we have the eosinophilic myeloblast, then the eosinophilic promyelocyte, eosinophilic myelocyte, eosinophilic metamyelocyte, eosinophilic band forms, and the formation of the eosinophils. From the colony-forming unit basophils, we have the basophil myeloblast, basophil promyelocyte. The next stage is the basophil myelocyte, then the metamyelocyte and the basophil band form, and finally to the basophils. From the common lymphoid progenitor, we have the precursor T and NK cell, from which the T cell and the NK cell develops, and from the precursor B cell, pro B cell, we have the B cells and the plasma cells. Classification of the leukocytes. Leukocytes are divided into two types, the granulocytes and the agranulocytes. In the granulocytes, we have the neutrophils, eosinophils and basophils, and the agranulocytes, we have the lymphocytes and the monocytes. Stages in the formation of the mature neutrophils are the myeloblast, promyelocyte, myelocyte, metamyelocyte, band cell, and the segmented neutrophil. In the myeloblast, they are around 15 to 20 micron. They have a large to oval nucleus with 2 to 5 nucleoli, and the chromatin are dispersed. And in the promyelocyte, which is larger than the myeloblast, which has a large round to oval nucleus, and the presence of the azurophilic granules in the cytoplasm with 2 to 5 nucleoli. The myelocyte stage, it is the last mitotic cell division. In that the nucleus is eccentric and there are presence of granules in the cytoplasm. Then we have the metamyelocyte stage, in which the nucleus is indented form with the presence of granules in the cytoplasm. Then we have the band cell, in which U-shaped or the band-shaped nuclei is present with the chromatin, which is clumped. Then we have the segmented neutrophil, which is 2 to 5 lobes with the chromatin strengths. Neutrophil, the size is 13 micrometer and segmented nucleus with pink or orange cytoplasm and stain. There are several types of granules like the azurophilic granules, the specific granules, and the gelatinous granules, and other subcellular organelles which are present are the secretory vesicles, plasma membrane, cytoskeletal matrix, neutrophilic lipids, and the cytoplasmic lipid bodies, cytosol and the nucleus. The plasma membrane of the neutrophils includes the membrane, channels, adhesive proteins, and receptor for the ligands, ion pumps, and ectoenzymes. For example, CD11 and CD18 and CD62L, that is L-selectin, which helps in the adhesion of the leukocytes, the formylpeptide receptors, and the C5A, which sends the stimuli and activate the neutrophil. Aminopeptidase N, CD13, inactivate the interleukin 8, which eliminate the chemotaxis activity. CD10 can inactivate the chemotactic peptide, and CD66A and 66B and 66C can activate the neutrophils. The eosinophil size is 12 to 17 micrometers with 2 nuclear lobes and eosinophilic granules in the cytoplasm. The 3 cytokines which help in the stimulation of the bone marrow production of the eosinophil are the interleukin 3, interleukin 5 and granulocyte macrophage colony stimulating factor. The granules of the eosinophil, they contain the major basic proteins and the peroxidase. The major basic proteins helps against the helminthic infections. Basophils. Basophils are less than 1% of the circulating leukocytes. They are compact, irregular, dense nucleus, and the nuclear segments, they fold upon each other. The mast cells and basophils, they are round, non-membrane bound and electron dense structures called the lipid bodies, which are a rich source of the arachidonic acid. They increase in number during the cell activation and are thought to be derived from the membrane catabolism, and there is rapid synthesis of the lipid mediators like the cyclooxygenase and the lipooxygenase. These are the pictures showing the eosinophil and the neutrophil and a basophil, eosinophil and a neutrophil. Then we have the lymphocytes. Two types are there, that is small and large lymphocytes. They have the small nucleus is round and slightly clefted with the coarse chromatin. Cytoplasm is basophilic, slight and visible as a thin border. On immunophenotyping, there are two types of lymphocytes, that is the B lymphocytes and T lymphocytes. The B lymphocytes are originated from the stem cells in the bone marrow. They help in the humoral immunity. They are differentiated into the plasma cells, and the immunological markers are the CD19, CD20, CD21 and CD22. The T lymphocytes, they originated from the stem cells in the bone marrow, mature in the thymus. They differentiated into the helper, suppressor and the cytotoxic cells. The function is in the cell-mediated immunity, regulation of the function of the B cells. The immunological markers are CD1, CD2, CD3, CD4, CD8, CD5, CD6 and CD7. Just a picture showing the small lymphocyte and large lymphocytes. The leukocytes, they play an important role in the acute inflammation. They are recruited from the blood into the extravascular tissues. The leukocyte recruitment is a multi-step process in which there is margination and rolling along the vessel wall, which is with the help of the selectins, form adhesion to the endothelium with the help of the integrins, and transmigration between the endothelial cells with the help of the platelet adhesion cell adhesion molecule, endothelial cell adhesion molecule 1 or the CD31, and migration in the interstitial tissues. There's a picture showing the leukocyte activation recruitment, in which in the blood vessel, the red cells, since they are small, they tend to move faster than the leukocytes. So that for the inflammation, the leukocytes, they have to be into the extravascular tissues, so they are pushed into the border of the vessel wall. After that, they get to interact with the endothelial cells. Firstly, the selectins, they help in the adhesion of the leukocyte to the vessel wall, but the adhesion is not firm. They start rolling, and after that, the integrins, they come to play into the role. Because of the chemokines, the integrins, they are converted into from a low affinity state to the high affinity state. After the integrins ICAM1, the TNF alpha and the interleukin 1, they induce the endothelial expression of the ligands for the integrins, that is for the ICAM, for the leukocyte factor antigen and the macrophage antigen. After that, there is transmigration into the endothelial cells, which is with the help of the PCAM or the platelet endothelial cell adhesion molecule 1. After that, they are extravasated into the tissues. There is chemotactic stimulus, after which they are phagocytosed. The nature of the leukocytes varies according to the age of the inflammation. In less than 24 hours, the neutrophils come play into role, and after that, after 24 to 48 hours, the macrophages, they come to play into role.
These selectins have been identified that have an N-terminal domain homologous to calcium-dependent lectins. These are initial rolling interaction mediators. The ligands are sialylated oligosaccharides bound to mucin-like glycoproteins. The deficiency of these translates to leukocyte adhesion deficiency disease type 2. The expression of selectins and the ligands is regulated by cytokines produced in response to infection and injury. leukocytes express L-selectin at the tips of microvilli, which then express ligands selectins E and P, all of which bind to the complementary molecules on the endothelial cells. Integrins, these are non-covalently associated heterodimers of alpha and beta subunits. The weak rolling interactions slow down the leukocyte and give them the opportunity to bind more firmly to the endothelium, as explained in short by my colleague. Tumor necrosis factor alpha and interleukin-1 induce endothelial expression of ligands for integrins, mostly vascular cell adhesion molecule 1, the ligand for beta-1 integrin VLA4, intercellular adhesion molecule ICAM1, the ligand for beta-2 integrins LFA1 and MAC1. These are the summary of selectins and integrins. The selectins we have 3, the L-selectin, E-selectin, P-selectin, also known as CD62L, E and P simultaneously. They are expressed on different cells. The L-selectin is expressed on neutrophils, monocytes, T cells and B cells, which can be naive, and T cells also of central memory, whereas E-selectin, P-selectin are expressed more on the endothelium and are activated by cytokines. Whereas in integrins, the leukocyte factor antigen is mostly seen on neutrophils, monocytes and T cells, whereas the macrophage integrin is seen on monocytes and dendritic cells. Whereas the very late antigen 4, VLA4, is seen on monocytes, T cells, and then we have CD3, which is also known as platelet endothelial cell adhesion molecule, which is in endothelial cells and leukocyte. Leukocytes which have been recruited to the site of infection or tissue necrosis must be performing these functions: phagocytosis of particles, intracellular destruction of phagocytosed microbes and dead cells by substances produced in phagosome, liberation of substances that destroy extracellular microbes and dead tissues, production of mediators. Hence, we will see if there is a defect in the neutrophil or leukocyte adhesion or integration, then these functions will be affected. Accommodations of eosinophils involve the interaction of alpha-4 and beta-2 integrins with the endothelial layer. Specifically, eosinophils adhere to tumor necrosis factor alpha, interleukin-1, beta, and lipopolysaccharide activated human umbilical vein endothelial cells through ICAM1 and BCAM1 interaction. The mediators produced by the mast cells are responsible for most of the manifestation of immediate hypersensitivity. In the late phase reaction, leukocytes are recruited that amplify and sustain the inflammatory response without additional exposure to the triggering antigen. Eosinophils are often an abundant leukocyte population in this reaction. As we can see in the case of IgE activation, it produces two changes. It first causes degranulations, which causes the release of histamine and proteases, and it also signals the nucleus to release cytokines and membrane phospholipids. Then it causes platelet aggregation factor release and arachidonic acid release. Then this evolves into prostaglandin D2 and leukotrienes B2, B4, C4 and D4. The leukocyte function defect can be genetic or it can be acquired. Genetic, we have examples: leukocyte adhesion deficiency, which has 3 variants, 1, 2 and 3. In one, there is mutation in the beta chain of CD11 or CD18 integrins. In deficiency 2, mutation in the fucoyl transferase, that is sialylated oligosaccharide that we have seen earlier. Leukocyte adhesion deficiency defect in the integrin activation. Then there is chronic granulomatous disease, which has 2 variants. It can be X-linked or autosomal recessive. Chronic granulomatous disease is usually concerned with decreased oxidative burst, but in X-linked there is the membrane component that is involved, and in the recessive there is the cytoplasmic component that is involved. Myeloperoxidase deficiency is defective in the myeloperoxidase and hydrogen peroxide system. Chereak-Higashi syndrome, mutations affecting proteins involved in lysosomal involved traffic. In acquired causes, we have bone marrow suppression due to tumors, radiation and chemotherapy. These result in the decrease in the production of leukocyte. Diabetes, malignancy, sepsis and chronic dialysis, which are commonly encountered in immunocompromised state. This results in deficiency in the adhesion and chemotaxis of leukocytes. Then anemia, sepsis, diabetes and malnutrition also can cause phagocytosis and microbicidial activity. Congenital leukocyte adhesion deficiency disease. It is a rare autosomal disorder. The blood counts will show marked leukocytosis. However, due to deficiency of adhesion and migration, the neutrophils are not able to reach the site of tissue necrosis or injury. Defective neutrophil adhesion to endothelium, absence of extravascular neutrophils, and this causes recurrent life-threatening bacterial infection, which are commonly in the skin or the oropharynx or around the in the dental area. The first variant, leukocyte adhesion deficiency 1, this is also CD11 or CD18 deficiency. It is in the defect in the biosynthesis of beta-2 chain shared by the integrins late leukocyte factor antigen 1 and macrophage integrin. The gene mutation is ITGB2. Example, the patient commonly presents as high neutrophil counts or recurrent infection, or the baby will come with a delay in detachment of the umbilical cord stump. Bacterial and fungal infections are common. Skin and mucous membrane, middle ear and oropharynx. The wounds heal slowly and may also lead to additional infections. There is also lack of pus formation at the sites of infection due to lack of recruitment of neutrophils at the site. Due to repeated infections, the life expectancy of individuals with leukocyte adhesion deficiency 1 is shortened. Defects in motility, phagocytosis, granulocyclation, particle-stimulated respiratory burst activity, humoral and cellular immunity, lymphocyte stimulation tests are normal. No specific enzyme deficiency are detected. In leukocyte adhesion deficiency 2, the mutations in the fucosyl transferase required for synthesis of sialylated oligosaccharide. In this disorder, along with the already discussed clinical features of leukocyte adhesion deficiency 1, there are also features like mental retardation and Bombay blood group. Then there are distinct facial appearance, which is signified by the depressed nose. Pneumonia, otitis media, periodontitis, localized cellulitis without accumulation of pus. The Bombay phenotype is a deficiency of fucose alpha 1 to galactose linkages, which serve as a core of the A, B, and O blood groups. Leukocyte adhesion deficiency 2 neutrophils lack CD15 expression and do not bind interleukin 1 beta stimulated endothelial cells. In this disease, the neutrophils do not roll well on the endothelial cells and do not adhere under stress. Oral fucose supplementation may be helpful in this disease, and bone marrow transplantation is considered in some cases. Leukocyte adhesion deficiency 3 is an autosomal recessive disorder. In this, along with the recurrent infection, there is also Glanzmann thrombasthenia type disorder because of the deficiency of the platelets to attach to the endothelial cell or to the site of injury. That is why this patient also presents with bleeding tendencies. Mutations of FERMT3 or kind 3 codes for Kindle3, a protein that associates with beta integrins, interfere in both leukocytes and platelets. Severe leukocyte adhesion defect and Glanzmann type thrombocytopathy, they are also recurrent infections. There is also some very rare diseases that are described. There is RAC2-GTPase mutation, a defect of neutrophil adhesion, oxidase activation, degranulation, and chemotaxis in response to chemoattractants. While the differentiating feature is that it has double negative mutation in RAC2-GTPase enzyme. Leukocytosis with the deficiency of pus at sites of infection. As unlike the earlier diseases, we have seen where there was no pus formation. Myeloperoxidase deficiency, autosomal recessive, mutation in the myeloperoxidase gene to chromosome 17q23. In myeloperoxidase deficient neutrophils, intracellular killings of microorganisms is low, but ultimately it is itchy. Susceptibility to bacterial and fungal infections, more common for fungal infection like Candida. Chronic granulomatous diseases, mutation in one of the 5 genes encoding for subunits of neutrophil NADPH oxidase. Hence, there is a deficiency of this enzyme. Mode of inheritance is X-linked recessive, while in some it is autosomal recessive. Defective killing of bacteria by neutrophils. Recurrent infections by gram-positive as well as gram-negative organisms. Common sites of infections are lung, skin, lymph nodes, gastrointestinal tract, and bones. Diagnosis by nitroblue tetrazolium dye test. Treatment is prompt and aggressive treatment of infection, surgical intervention when required. For long-term prophylaxis, cotrimoxazole is advocated. It has 2 variants, X-linked and autosomal recessive. X-linked is more commonly found and transferred on X chromosome. Mutation in CYBB gene on the X chromosome encoding for GP91 NOx2. Defective leukocyte bactericidal capacity. Using the nitroblue test, Female carriers can have mixed population of neutrophil. One half can be the dye positive and one half can be the dye negative. Then there is another rare entity, FCYR3 deficiency. They lack the IgG receptor FCY3b. These patients can either be normal or have multiple infections. Then there is Chediak Higashi syndrome, rare autosomal recessive disease. This is characterized by abnormal large granules, because of which the secretions are there, or the substances are present in the granules, but they are not functionally effective. The features are immune deficiency, poor resistance to bacterial infection because of accumulation of large granules in the leukocytes. Oculocutaneous albinism because of accumulation of large granules of melanin. So despite the melanin being there, it is functionally ineffective. Bleeding tendency because the accumulation of granules in the platelets, and platelets are not functionally effective. Multiple neurological anomalies because such large granule cells are also seen in these cases in the nervous system. Giant peroxidase positive lysosomal granules in granulocyte, and accelerated lymphomatous illness with lymphohistiocytic infiltrate in numerous organs develop in most of the patients. It can be characterized by fever, jaundice, hepatosplenomegaly, lymphadenopathy, pancytopenia, and bleeding. It results from mutation in the CHS1 gene, also called as LYSG, lysosomal trafficking regulator gene, located on chromosome 1q42.1 and 1q42.2. Infections require aggressive microbial therapy. Once the diagnosis is established, prevention of infection is the key with prophylactic antibacterial and antiviral agents. Accelerated phase is managed with immunosuppression. Hematopoietic stem cell transplant is the treatment of choice. These are my references. Thank you.